It's a real privilege to be able to come and chat to you guys and to just talk about these two really important diseases and diseases that affect so many of us, and hopefully give you some pointers as to understanding why we have these problems that we do have with dry eyes and with glaucoma together, and to look at some options, what we can do to try and reduce that. Um, I suppose the key thing to understand is that these are two very complex diseases that we try and simplify. We try and say, well, glaucoma is just raised pressure. All you got to do is drop the pressure, and then then you treated the disease. Or dry eyes is just the tears are not very good. You could have put more tears in the eye, and you'll be fine. And on a very, very superficial level, that's accurate. But truthfully, there's a lot more detail in there and a lot more to understand with each of these diseases. I don't really need to tell you this because you guys live with these diseases and one or both diseases. And I'm hoping that we'll find ways to try and mitigate the effects of these diseases. Neither of these diseases can be cured, but we can manage them. And what I found over time with my practice is I used to do a gently, softly, softly approach for each of these diseases, but I'm a lot more interventional these days. I like to really hit it on the head and stop them from getting worse early on. And that helps me over the years to manage my patients. My glaucoma patients, especially while I was still in the UK, because those who may not know me, I qualified in medicine in South Africa. I went to the UK and I was there for 22 years and worked in ophthalmology and have vast experience in managing both glaucoma and dry eye disease. I was one of the really top dry eye disease experts there, and I have a very good understanding of these conditions. I've been in New Zealand 4 years, so I'm coming to get to grips with the way that New Zealand runs things and with the pros and cons of living in such a beautiful and almost remote place. One of the things that we know about glaucoma is that it's a gradual disease that's more prone to be in the elderly, and dry eye disease is also more prone to be prevalent the older we get. So about if the general population, there's various studies, but in dry eye disease in the general population, around 20 to 30% of the general population have dry eye disease. And with glaucoma, you look at the population of people with dry eye disease and glaucoma, we're looking at about 40 to 50% of people with glaucoma have dry eye disease. So I'm going to flip to my first slide here. So what we know about glaucoma is that the treatment of glaucoma requires us to create a little bit of inflammation in the eye. Those of you using a prostaglandin eye drop will know that you have a slight redness to the eyes, and that redness is just because we need a bit of inflammation to open up the pores, open up the drainage system, get the macrophages activated. That's the thinking behind some of the laser treatment we give. And we need to get a bit of inflammation going. Whereas dry eyes, it's an inflammatory disease. So inflammation worsens dry eye disease. And I think that's where one of the major overlaps are. The other thing we need to know about all three of, or both of these diseases is it's going to cost us in some way to get these diseases. Once you've got this disease, it's going to cost you. It's going to cost you money, particularly in dry eye disease, where there's not such great funding for the dry eye disease products. But also in glaucoma, if we're looking at preservative-free drugs, yes, we have some now in New Zealand, but they're not funded by the government. So there is a financial cost. There is a cost in time when you have to stop, you have to put the drops in, you have to go to the pharmacy and stay up to date with the getting your prescriptions, and you need to see a clinician. Because these conditions, as they develop, they don't follow a straight line. It's quite hard to predict how the glaucoma is progressing or how the dry eye disease is progressing. So the best way to figure that out is to come and see a specialist, and we will keep track of that for you. We can see and measure the changes these days a lot more accurately. Some patients I have to see every 3 months or 6 months or some 9 or 12 monthly, I can see them. And I get to know my patients, and I get to know that little bit of redness in the corner of the eye. With one patient, I can say, just give it time, it'll settle down, just blink more often, and you'll be okay. Others, I see a little bit of redness, and like, we've got to get on top of that. Let's give you some steroids, let's give you some intensive lubricants, let's change your medication. So it's getting to know your disease and getting to know your clinician who's managing your disease. So that's time investment in that. And obviously, I live in Rotorua, and we have patients that travel hour and a half to come and see me for a 15-minute consult. And I appreciate the commitment that it takes, the time in the waiting room, time to see us, time to do all the tests. It takes a lot from us. And then obviously the emotional, mental energy, particularly when you have a disease like glaucoma, that if we don't manage, you will be losing sight. You'll be given more options. You'll be talking about maybe laser, maybe surgeries. You may be fearful of losing some sight. You may indeed have lost quite a significant amount of your sight. And the mental energy of planning things, especially with dry eye disease, you've got to plan. I'm going to get onto an airplane. I must make sure I've got my lubricants with me. I'm been using my lubricants regularly. Planning to get the different treatments, putting it all and getting into a healthy routine and a schedule, both with the glaucoma drops and with the dry eye stuff. So there's a lot of mental energy that goes into it, anxiety and concerns around it as well. So why do we suffer more with dry eye disease when we have glaucoma? And as I said, glaucoma is an inflammatory disease driven by inflammation, and glaucoma creates a bit of inflammation in order to treat the glaucoma. In chucking anything into your tears, it's going to disrupt the normal tear layer. The tears are composed of two layers. The first one is a gel, which is a mixture of mucus and water. So it's a thick gel that smears up on the surface of the eye. And then there's a very thin layer of oil that prevents the gel from evaporating too quickly and becoming all sticky and irregular. So we need this fine balance of the tears. And the more you chuck things in, the more you're just going to disrupt it. As we get older, we're going to get more high risk of having glaucoma. And we get a high risk of having meibomian gland dysfunction, which is one of the major causes of dry eye disease. And the thing I'm really, really passionate about changing here in New Zealand is access to preservative-free drops. Many of you, I wish I could have a show of hands type thing, but many of you are using 2, maybe 3 drops a day, maybe up to 5 drops a day of your glaucoma medication. And if these are preservatives, these preservatives are there to kill and destroy bacteria so that the bottle of your glaucoma medication stays free of bacteria, and that's important. But you put this preservative in the eye, we make drain cleaner out of these preservatives. They are strong, although it's a very, very small amount in the bottle. But over time, putting that in is going to cause inflammation, and dry eye disease is an inflammatory disease, so you're driving up your dry eye disease. For those of you who use dorzolamide, or the combination I use quite commonly here is dorzolamide and timolol. Dorzolamide has a bit of a acidic concentration in it in order to let the chemicals float equally in the bottle. So you're putting a drop in, and that it's an equally dispersed amount of medication getting into your eye, but it is a bit acidic. So if you already have dry eye disease, and we know in dry eye disease, the surface of the eye gets lots of little fine hairline cracks and tears in it. So if you're putting an acidic drop into an eye that has lots of hairline cracks and tears and breaks, I sort of think of it like I come from Africa, and there we would have a lot of droughts, and you'd have a river that dries up, and you see that riverbed full of fine cracks all over it. And that's when I put fluorescein in a dry eye patient's eye, I will see those cracks physically in the surface of the eye. And then you're putting an acidic drop in there, it hurts. And the key thing we want with glaucoma is compliance. That's the key thing. You have to put the drops in, and you have to put them in regularly. If you stop using it, your pressure is going to go up and you're going to lose some sight, and we just can't get that back. So if you've got dry eyes and you've got a stingy drop, it's a problem. Surgery. So in glaucoma, there are various options, and I'm pleased to say there are more surgical options in glaucoma these days. But every time we cut into the eye, we are generating some inflammation in the eye. This inflammation drives the dry eye disease. Also, when we cut into the eye, we are cutting some of the corneal nerves. Now, they do regenerate, but it may be why soon after your glaucoma surgery or your cataract surgery, your dry eye disease will flare up. So there are a number of reasons why people with glaucoma will have more cases of dry eye disease. And my impression is that my glaucoma patients have a severe form of dry eye disease. They're very symptomatic from it. So what can I do? What advice can I give my patients? And at the moment, from a glaucoma perspective, so if I wear my glaucoma hat, my glaucoma ophthalmology hat on, there are a number of things I like to dip into. Some much more effective than others, but I think something like health and exercise has been shown to be helpful to my glaucoma patients. Various laser interventions, various surgical interventions, and the main reason we are moving from a drop-based glaucoma approach to these more interventional approaches, firstly because the technology is coming on and we have some really fantastic solutions for our patients. But the second thing is the less drops you have to put in the eye, the less the surface of the eye gets damaged or inflamed and disrupted because of the drops that we have to put in the eye. So the whole drive is, I think, probably in about 10 years' time, maybe in the States, it'll take a bit longer to come through to New Zealand. But in around 10 years' time, we're going to have more and more options that we don't need to be putting in drops all the time. And also there's going to be changes where you can have your pressure measured at home and you don't have to come into the clinics as often. We know that there's an exploding population of patients with dry eye disease and with glaucoma all over the world. We're very lucky to be in a first world country here in New Zealand and have access to a lot of very good physicians and treatments. But in places like Africa, where there are a lot of glaucoma patients, they're just underdiagnosed and undermanaged. These future changes are going to really help them, but help us too. So if I look at something like the health and exercise. Now, health and exercise, this is something I get asked about a lot by my patients. And there's no hard and fast answers for this. I think common sense has to prevail here. And we know being healthy, having a good cardiovascular system will help us. There was a study that was done 22 years ago, so a long time ago in the States, where they looked at complementary medicines that people and approaches to health that people were using. And this is the number of people that were actually using it. But when we've reviewed the actual scientific data, there's not very strong data supporting these, but I do think they are healthy. And I'm definitely one who's open to looking for other support as well as all the Western medicine approaches to glaucoma. So we know that on this study, again, long time ago, almost 5 to 6% of patients were using alternative options. And I've seen someone split this into 3 different groups, and that's things we can take, things we can do, and things that we think. So things that we can take, there are options that people are talking about, and I know omega-3 has been pushed forward as an option, particularly in dry eye disease, although again, the evidence is not strong, but also in glaucoma. And anti-inflammatory type diet is something else that people are looking at a lot. But herbal therapies, as I said, an anti-inflammatory diet for diet modification and homeopathic therapies. Things we can do, exercise. Now, exercise is a really, really important part of maintaining a healthy cardiovascular system. And glaucoma is just plumbing. It's just either you're producing too much fluid or you're not draining it out enough. And having a healthy cardiovascular system is only going to be beneficial for the eyes. But again, it's hard to get the science and the scientific data points for these, but I do definitely recommend it. Acupuncture has been used before. Some people really get good benefits from it. Meditation, faith healing, and the power of the mind is unbelievable. And I don't think we tap into it sufficiently. Yes, we do need to keep doing our drops. We do need to look into our regular surgeries and treatments. But these are things that are also important. And I do think as a holistic approach, these are sensible things for us to do. Lasers. So lasers have come on leaps and bounds. And again, the drive behind lasers is to reduce the amount of drops. A very, very important study called the LIGHT study, which is called the Laser in Glaucoma and Ocular Hypertension trial. This has changed the way we practice glaucoma. And again, I wish I could ask you to put your hands up if you've had SLT, which is called selective laser trabeculoplasty. I've put a little picture on my slide there of how we laser the drainage system of the eye. Now, the drainage system is like a sponge. And if you've ever had an old sponge that's been lying around for a long time or been used a lot, you'll know it loses its ability to absorb. And it gets full of a lot of debris, and it just doesn't soak up fluid anymore. And the same thing with the drainage system in your eye, the trabecular meshwork. The strands, each strand thickens, and therefore the gap between the strands narrows as the strands thicken. So when we shine this light on it, on the eye, now it's a very gentle light. You won't even know you've had laser treatment. If you have selective laser trabeculoplasty, some patients get a mild inflammation afterwards. But essentially, you sit on a slit lamp looking machine, very similar to what you would have sat on just to have your eyes examined in the normal clinic room. But with our clinic, you'll go to the treatment room where there's a laser device. You put your chin on the chin rest, head against the front. We do put a little coupling fluid and a small lens against the surface of the eye, obviously after numbing it. Then we just shine a laser beam. You sit there, you hear beep, 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 maybe 2-3 minutes, and you'll sit back and it'll be done. I do give my patients anti-inflammatory drops afterwards for a week, and you might need your pressure checked soon after, just to check that it's fine. But the whole idea is you're producing a bit of inflammation in the sponge so that the natural healing cells, the macrophages, they go up and they gobble up all the debris and they look for why there's inflammation, and they leave these strands thinner so the gaps between the strands are larger and therefore more fluid can flow out. Now, the SLT needs to be repeated every 3 to 5 years, maybe sooner, but for 80% of patients, it can be really effective. And definitely in my practice, something I'd love to have is first-line treatment for my patients with glaucoma. So if you're diagnosed with glaucoma and you come and see me first time and I can give you this SLT treatment, you may never need drops for 3 or 4 years. And if you do, then we just repeat it. If after the first SLT treatment, your pressure hasn't come down sufficiently, then I might have to give some drops in addition, because we know 20% of patients don't respond to the SLT laser treatment. So that's a really good solution, a very effective solution for my patients. And if I can keep you another 3 years off drops, then it's going to be really a lot better for your glaucoma and your dry eye disease. So that's SLT. There are obviously other lasers that we can give. Depending on if you have narrow angles, then you need a certain kind of laser. This isn't laser vision correction. This isn't the smile therapy or the other laser vision correction. This is actually specifically for glaucoma. Now, there is another very clever laser machine that can switch off the production of aqueous in the eye, so to turn off the tap, as it were. And that's often kept for late stage glaucoma patients, but we do have other options. So the next thing I'll move on to is surgeries. Now, I've spoken to this group earlier about MIGS. MIGS is a minimally invasive glaucoma surgery, but there are different parts in the eye that can benefit from surgical devices. And it's a relatively new field, and a lot more of these treatments are being given these days. So it could be a little implant that we plant in through the sponge to bypass the sponge, something called a stent. So stents help to bypass between two chambers. So it bypasses that sponge, so you don't need to worry about that. There are surgical techniques where we enlarge where we take some of the sponge away, just to allow direct access between the fluid in the front of the eye and the drainage system. There are ways that we can bypass from the inside of the eye, out of the eye, under the conjunctiva, but out of the eye. So there are some minimally invasive things. These can be done during cataract surgery. And again, I'd be keen to know how many people have actually had these stents or these surgeries done. I'm sure there are a fair few of you. Now, the advantage of these, again, is that we can actually, so I spotted a chat pop up, and I was just wondering if there's a warning that I'm going over my time. So yeah, please do feel free. If you have questions, definitely ping the questions in the chat. There should be a button along the top called chat. Click on that and you can add in questions for me now. Or I might just ask Jenna to collect the questions, and she can always ask me the questions at the end as we go along. But if you have some burning question, please do pop in the chat and I'll be able to stop and talk to you. So the whole drive behind these surgeries, in the past, glaucoma was managed basically by one big operation called a trabeculectomy. Now, it's still a fantastic operation and it works very well for many of my patients. And I have patients who've had very severe glaucoma who are being managed very well after a trabeculectomy on no drops. Then pilocarpine was the first drug to be discovered. 100 years later, we discovered beta blockers, timolol, that I'm sure lots of you are still on. And then the prostaglandins more recently were the latanoprost, bimatoprost, and travoprost eye drops. So the drops have progressed, and we were like, oh, this is great, we've got drops. But then we started to realize the drops are causing problems, but the drops weren't causing as many problems, or they weren't as risky as the big trabeculectomy surgery. And now what's happened is we've got these minimally invasive surgeries. So now we're saying, well, we don't have to do the big trabeculectomy necessarily. We can try and get patients either off drops, or we do this instead of drops. So it's becoming more invasive. So I think over the world, my experience is that my colleagues are definitely becoming more proactive in looking for surgical procedures, surgical techniques, because they have lower risk and they can save you from having any drops or minimizing your drops. So the more and more we can do that, the better it is. And I would definitely, especially if you're planning to or due to have cataract surgery, ask the surgeon, hey, is there any chance I can help control my pressure during the surgery? Either the eye stent, which can be quite expensive, or there are different surgical techniques where we can open up the trabecular meshwork during surgery that doesn't necessarily need a stent being put in. Obviously, stents are one of the ways, but there are other tubes and ways that we can do this for the early stage glaucoma patients. So surgery and then drops. So ideally, we want no drops. So you come in, you've got glaucoma, I do SLT, and you don't need drops. And we keep monitoring you as we normally would. Or if you're on a lot of drops, I can do SLT or one of these eye stent or other MIGS procedures to reduce your dependency on drops, and doing it earlier rather than just waiting until you're failing and then we do these procedures. Preservative-free drops. Now, this is really something that I know the Glaucoma Association are really working hard on pushing and lobbying to get. We have some that are available, but you need to pay for them, and they can be quite expensive. And if you have severe enough dry eye disease and it's a awful disease to have that chronic pain in your eyes constantly, that might be an option for you. Timolol, there's a way that we can ask for special funding for timolol. So if you have dry eye disease and you're on timolol and your eyes are burning, ask your physician if you can ask for a Section 29. We call it Section 29, and they can get or request at least special funding for preservative-free timolol. And if it's one preservative or two preservatives less in a day that you're putting in your eye, the better. Also, the longer you've been on preservatives or eye drops with preservatives, the more likely a trabeculectomy is to fail if you have to go that far to get a big operation called a trabeculectomy for your glaucoma. It's more likely to fail the longer you've been having lots of preservatives in the eye. On my slide, I've put in an anterior chamber implant. That's not available in New Zealand at the moment, but there is an implant that we can pop into the eye, and it lies in between the colored part of your eye and the clear window, and it gradually releases medication to which bimatoprost, which controls the pressure for a long period of time. So even in the States, I don't think it's been licensed to be used like as in every 4 months. Because I think it lasts for 4 months. Again, we don't use it yet, so I don't have experience of it, but I'm just looking at what's coming and what we can do. One of these implants, you can have, I think it's 4 months that you can go without eye drops. So we can call them like an eye drop holiday. So if your dry disease is really flared up, when we get these in New Zealand, that's an option for us. We pop one in, and you can have it you can have an eye drop holiday while this implant slowly releases the medication into your eye. And there are more in the pipeline, because this is really an area of growth. Taking the responsibility of remembering to put eye drops in every day, and that time wastage and the mental space that we can take away from patients having to worry about these things, and we can take over by putting a little drop in an implant in your eye, is the way we're going to be going in the future. So I'm going to touch briefly on dry eye disease now. So that's what we can do with glaucoma. So dry eye disease, very similar. I like to think of these as buckets, 5 different buckets, and I tend to pick 1 or 2 options from each of these buckets. In the past, 2006 possibly, when I really got passionate about dry eye disease and managing glaucoma, we basically had 2 or 3 options. So it was easy to follow a pathway. Patient comes in with dry eye disease, give them this medication, that doesn't work, give them that, that doesn't work, give them that. And that was what you had. You had 3 options, and we'd follow the steps. Now, what we're able to do is give individualized care for patients. We are getting more and more options, and unfortunately still not funded options, which is a real frustration for me here. But we are getting more and more options for patients. So there's an advantage there, because I can individualize the treatment for your dry eye disease. But there's also a disadvantage, because you're suddenly overwhelmed with all these options, and you don't know which one's right and which one's wrong. My top level view is nothing's wrong, and I think you need to try all of them and find one that works for you. And you'll find one that works best for you. I mean, I've gone to a lot of conferences, and I go to all the very big international dry eye conferences, and they'll say, oh, this is the very latest, very best drug. Use this drop, it's very good. And I go home with a sample, I try some on patients, try it in my own eyes, because I suffer from dry eyes. And it may work for 1 or 2 patients and not work at all for others. So there's no one silver bullet to solve this. We need to find a combination that works best for you. So a combination of a bit of lifestyle changes, some drops, assistive devices, oral medications, surgery. So drops, great to have options in dry eye disease of preservative-free drops. And I think there's going to be more and more preservative-free drops becoming available in New Zealand, but we've got a fair number, again, just not funded. The price I don't know, around $30. But for some of them, they usually have around 300 drops in, which should last you for 3 months. That's the other advantage of the preservative-free drops. You don't need to throw them away after 28 days um, because they remain safe for a very long period of time. Drops, which ones is the best one? Again, I often say to patients, look, try 2 or 3 or take 2 or 3 drops and you get different thicknesses. Now, I don't use the very thin ones, the hypermellows. I know that it only lasts on the surface of the eye for 15 minutes from when you put it in, and they all tend to be preserved. So I go for a hyaluronic acid eye drop or something with a gelling agent like Systane or something with polyquat in. So these are different agents that mimic the gelling, the gel layer of the front of the eye. So when I first started in ophthalmology, we used to give normal saline or salt solution, which is kind of one of the worst things we could have done. But at least we had something for our patients with dry eyes. But now we've got some very clever agents to put in the eye. So some patients, if I take the high-low range, you get high-low fresh and high-low forte. High-low forte is very thick, and high-low fresh is a thinner version of it. And some patients like to mix and match. In the morning, maybe they'll use the thinner. Towards the end of the day, they'll use the thicker high-low forte eye drops. I'm a great believer in ointment at night. A lot of people, you'd be surprised how many people have their eyes open at a very small slit in the evenings, and that just desiccates or dries out the eye quite badly. So ointments are good, and the modern ointments are a lot better than the first ones we used to have. You used to be literally blinded when you woke up. There would still be very thick, gloopy ointment on your eye. Today, the ointments are a lot better. Serum eye drops, that's a fantastic solution. I worked on a lot of trials on eye drops in the UK, and I find the serum eye drops are very efficient for my very severe patients. Again, it's a lot of mental energy going around organizing, collecting, looking after your serum eye drops. But they do work very, very well if you have such severe dry eyes. So do speak to your clinician about serum eye drops if you are struggling. Steroid eye drops, I use that for a short, sharp burst. Again, dry eye disease is an inflammatory disease and the inflammation drives it. And if you're putting prostaglandins, a glaucoma medication in your eye, or having surgery, then you may want to dampen that inflammation down with a short burst of steroids. They have side effects, but they can be managed well. Obviously, drops, you have drops that have oil, the oil layer. Remember, I mentioned the gel and the oil layer. So there are some with the oil layer. Dry eye disease, if I can split it into 2 major categories. The one category is dry eye disease where you're not producing enough water. This tends to be younger patients, or patients with rheumatoid arthritis or autoimmune diseases, where the production of tears is damaged. Most patients, though, have the evaporative dry eye disease where the oil layer is broken down. So there are little oil glands in your eyelids that produce oil and little droplets of oil. And when your eyes blink, those droplets merge together to form a thin layer. And as you open your eye, that thin layer is spread out onto the surface of the eye. And if that thin layer is too little volume or poor quality of the oil, then you get an irregular layer pulled over the eye. And a lot of the symptoms include problems with, say, blurring of your eye. So I'll have some of my glaucoma patients coming to me and say, oh, my eye's blurry. And I'll ask them first thing, does it change when you blink? And it's yes, when I blink, if I blink 5 or 6 times, it can change. That's also, it's almost reassuring for me because glaucoma won't do that, but dry eyes will. Obviously, the gritty foreign body sensation, but even the sense of being tired, particularly if you're on prostaglandins. And some of my patients, as they're starting prostaglandins, when the eyes get really red, it's as if they haven't had enough sleep and their eyes are really tired and sore. So that's one of the things, one of the other symptoms. So there are options with the drops and ointments. But again, please don't put, I don't think there's any reason why I'd ever put a preserved lubricant in my eye. There are good options available for us. Lifestyle choices. I mean, there are a lot of things we can do, sensible things. Diet is a really important one because you want an anti-inflammatory diet. You want to try and cut back on the inflammatory cycle in the eyes. Digital devices, it's hard to tell people. I think I've probably learned not to tell people. I got teenage children, so half my life at home is spent trying to get them to make sensible choices around the amount of time they spent on computers. And we have done studies where for 2 minutes, a child doesn't blink because he's been playing a computer game and doesn't want to die. If he blinks, he dies. But a lot of you read a lot, which is very good, and I want to encourage you to read, and I want you to enjoy your quality of life as much as possible. That's the reason I get up in the morning and I see my patients, because I'm really focused on quality of life. So if reading is a really important thing for you, then do it, but just be sensible around it. I think use your drops, a relatively thin drop before, and take breaks in between. But do read, do enjoy your eyes. But digital devices, we know we don't blink enough when we're on devices. Having a good regular dry eye treatment regime, hot compresses regularly, eyelid wipes, cleaning off your makeup at the end of the day. Make sure it's crystal clear, your eyelashes and your eyelids. Usual regular drops. If you're going to go into an environment like driving in a car on a long drive where they're using air conditioning, or a bus or a plane, or going to go sit in a waiting room in an eye department where they have a lot of heaters on, make sure you have your drops in ahead of time. Sunglasses, minimize fans, so all the things you can do in your environment. Look down slightly because that narrows your eyelids and gives you a smaller area for evaporation. We used to, in the UK, where we'd have radiators, we'd advise people to take a little container with water in to try and put it on there just to humidify the air a little bit. Or you can buy humidifiers that will do that. Regular good sleep, really important. And probably one of the reasons I have such dry eyes is I don't sleep regularly or enough. But that is really important, letting your eyelids, when your eyelids are closed over the surface of the eye, it's doing its healing. There are cells that go in, they capture debris, they repair the surface of the eye. And if you're not doing that regularly or not getting sufficient healing, then you're just putting damage upon damage upon damage. So good regular sleep. Systemic medications. It would be worthwhile either sitting down with your GP, but more likely with your pharmacist, and saying, look, I've got really bad eyes. Yes, my glaucoma medications, I get it. They are causing some problems. But what about these systemic medications? Is there anything I'm taking? And you'll be surprised. I forget the data now. I read a study of the top 100 selling systemic medications in America. I think about 40% of them had dry eyes as a side effect. So have a look at them, see if you can reduce them, change them, find other options. Contact lenses are a therapy for very severe dry eyes, but also they create more inflammation and irritation on the surface of the eye. And therefore, for mild, moderate dry eyes, they can actually be quite bad for the eyes. So if you can wear glasses, that's a good idea to wear some glasses rather than contact lenses, or give your eye appropriate breaks. Have a good contact lens hygiene. So lifestyle choices we can take. Home assisted devices. I've just skimmed over these because there's hundreds of them. Eyelid wipes. So depending if you have anterior blepharitis. So I mentioned dry eyes as two major categories. Aqueous deficient, where you have an underlying disease that stops you producing water, or you have the evaporative. So the evaporative is meibomian gland dysfunction. The glands that produce the oil, they're not functioning well. And a lot of my patients, it's menopause, it's hormonal influences that damage those glands or changes the quality of the oils. Menopause is a huge, huge, huge one. Other medications can change it as well. But the other thing is, if you have an infection of the eyelashes have natural oils in them and that have natural bacteria, which is great. But if you have an excess oil volume in the eyelashes, bacteria will start to grow there. The bacteria starts to multiply. As the bacteria multiply and become more and more, they start competing against each other. And these bacteria that are competing against each other, they create toxins. These toxins are lipases, and some of them are lipases, and they drop into the tear film and they break down oil in the tears. So your tear film will start to break down and the water will evaporate. So cleaning the eyelashes is really important. So there are commercially available eyelid wipes that I'd recommend. I'm not a massive fan of baby shampoo on the eye, because baby shampoo, it just destroys that lipid layer on the tears. So just be careful of baby shampoo. The eyelid wipes have been scientifically proven and used to and designed to use on the lashes. Skin sprays, there's one particular spray, hypochlorous acid, that you can spray once you've cleaned your eyes. You just squirt on your eyes, and what that does, that kills the bacteria. So the bacteria, or reduces the bacterial number. So that can help the eyelashes. Hot compresses, you guys know about that. There are mechanical, electronic hot compresses, and there are the microwavable bean bags. Please don't do a hot flannel in hot water. We did an experiment where we studied the effects of the eye, and the hot flannel is immediately too hot for the eye, and then it cools down by evaporation, and that the eyelids were actually left colder after the treatment of the hot flannels than actually before. So I'm definitely against hot flannels. Use the bean bags. They're designed to and tested to be effective. Intense pulse light therapy, and there are other light therapies available. There's some excellent work done at Auckland University on IPL, and worldwide now it's accepted as an effective treatment for some patients, particularly patients with rosacea, I'd recommend. But IPL is another important thing. So I'm coming to the very end now. I know I've been talking a lot, and I didn't get myself a glass of water. I should have done that. The other bucket I kind of pick out of, and something I think is really, really underutilized, and that's punctal plugs. So you produce water on the outside of the eye in the lacrimal gland. It washes across the eye towards the nose. And at the nose, there are two holes that drain the water away from the eye. And what we do is we plug one of those holes. And the one at the lower eyelid, that drains out 80% of your tears. So we put a little punctal plug to block the drainage system and allow the tears that are there to sit there for longer. And I've had patients who putting drops in every, say, 6 times a day into their eye, going down to 4 times or 3 times a day, which maybe doesn't sound like a lot, but over a number of days, weeks, months, that's a huge amount of that mental energy and stress that we can relieve by putting the plugs in. And I just had a patient the other day saying, I just changed her world by putting a punctal plug in. These plugs it's not painful. You're just sitting on the slit lamp. I do put a numbing drop on just because I'm fiddling close to the eye, and I just touch the eyelid, pull, and put a little plug in. These plugs, the various ones, you can dissolvable plugs. So if you don't like it, it only lasts for, say, 3 months and then dissolves. Or I like the silicone ones that I just pop in and I can remove if you don't like it. So puncture plugs are very important. Manual expression, that's something that I get quite, I like to do. I'm a bit of an expression fanatic. So when you come and see me and your meibomian glands, the oil glands the oil is meant to be thin like extra virgin olive oil, but over time and with hormonal changes and aging, the oil becomes thicker, so it's a bit cloudy. So I can press on it, and I press on the eyelid, and I can see that cloudy oil come out. But sometimes it can get thick like toothpaste. So you do a hot compress over the eye that melts the oils as much as it can. And then I do a sort of a tweezer on your eyelid, grabbing it and squeezing it and getting those oils out. And there's also a different way where you put some backing behind the eyelid and put pressure on. So if you come and I do a very good manual expression, it works for a very long time. And there are also machines that can do it, LipiFlow, one of the machines that I can think of, and there are other mechanical devices that you can put on the eye that help with this condition. There's a machine that's hopefully coming out to market in not too long time, and it's one that I helped develop. But you put it on the eyelid, it cleans the eyelashes, heats up the glands, and melts out the oils at the same time, all in one sitting within about a minute or two. So it's really good. Meibomian gland probing, I put that in there, but I don't do it very often. But sometimes if the meibomian glands have been inflamed for a long time, the opening of the meibomian gland gets very narrow. So I can stretch it open with a little probe and then allow the oils to come out. In practice, eyelid cleaning. So a lot of patients with very thick debris at the base of the lashes, it's really hard to actually get in there and to scrub it out because you can't see. You've got a little wipe on your finger that you're rubbing there and rubbing there. But in practice cleaning, is you can actually come in right at the base of the lashes. I have a little agitator brush that we sort of agitate the base of the lashes, cleaning away the debris and helping to actually get a crystal clear clean. And there's some lovely products out there we can use in practice. And that, I think, concludes my bit. I suppose in conclusion, I just want to say that we're dealing with some very complex diseases here, two complex diseases. One needs inflammation, and that one is made worse by inflammation. So that's one of the major reasons why we have problems with more severe dry eye disease symptoms in our glaucoma patients. And managing both of them aggressively, moving away from drops, so finding different techniques to move away from glaucoma drops. And one thing I didn't mention is using lubricants and drops together. There's ways we can do that to try and help things. So yeah, so I hope that it really helps you to understand a bit better behind these diseases and what's going on. And I'm open for any questions. Symptoms of dry eyes? Wow. So there's a question that's come up. What are the symptoms of dry eye disease? And the symptoms can range from just feeling tired, as I mentioned earlier, like the eyelids are just heavy, to fluctuating vision. So you'll see very clearly, and then you blink once or twice, and then it gets all blurry, and blink, and it clears again. To the common symptoms of a gritty sensation, and that's probably the most common, sand in the eye type gritty sore sensation, stinging, burning, worse in particular environments. Itching is not a very strong symptom. So once I have a patient coming in, their main symptom is itching of the eye, then you've got to think allergies and those other lines. So burning, stinging, gritty, problems watching television, problems reading for a long time, problems in environments that I know are dry, like airplane, driving with the window open, being near a fan or a fireplace. So those are the major symptoms. And then obviously signs like redness. But symptoms are mainly discomfort, blurry vision, just tiredness. If you've ever gone and you've only slept, say, 3 or 4 hours in a night, the next day your eyes are just gritty. And that's dry eyes.
I mean, I do get dry eye effects in both eyes, but it's definitely quite often just in my left eye that I really notice it.
Okay.
And yet I don't put any drops in my left eye,
Okay.
but I have to put the daily drops in my right eye. Yeah.
Well, it'd be interesting to find out what's driving the dry eye disease then, because there's going to be something underlying. And what can happen is these little glands that produce the oil, if they get very blocked and they continue to produce the oil, and that pressure builds up inside the gland, and it actually kills the oil producing cells in that gland. And then that gland shrivels up and gets very small. So there's something called meibography. And if you were a patient seeing me, or if you're going to go see a clinician, you can ask, can I have meibography done? And they just pull the eyelid down and take a photograph with an infrared camera. And that looks at the patterns of the oil inside the glands. And I started a new job, and the senior consultant said, I'm struggling with dry eyes on this patient. I'm trying to do hot compress massage. And I did meibography. She had one gland. She should have 30. She had one gland left. So it might be that you've lost a lot of those glands in that eyelid on the left-hand side. But we'd have to have a look at why that's the case in one eye. But that's that's the whole beauty about this, is that no two people are going to be the same.
Yeah. I do like clean my eyelids with a foam every morning.
Very good.
And I'm sure that helps a lot,
For
because
sure.
don't generally get the dry eye effects until sort of late in the day.
So the foam is designed specifically for anterior blepharitis. So that's one of the 3 big causes of dry eyes. So anterior blepharitis, if you clean the lashes, then you're doing yourself a huge favor at the start of the day. But it might be that it's the oil producing glands that might be your problem. It's low intensity light therapy. And it's a new thing. I've seen a few colleagues starting to use it. I haven't used it myself. I've read the literature around it, and it does look promising. It's not as intensive as the intense pulse light. And I would suggest trying it. I don't know enough about it right now, but I do know that it's some patients have been talking very highly about it. And in the chat rooms, I'm in a lot of the dry eye chat rooms, and they have been talking about it, with some saying it's worked very well for them, but I've also had a few patients saying that it hasn't made a big difference for them. Saying she said SLT 4 months ago didn't work. Dry eyes have become worse since the surgery. Is that common? Also wear hybrid contact lenses full-time due to keratoconus. Right. So SLT, as I say, works for 80% of patients. It's very dependent on when you're looking at the trabecular meshwork, we have to use that special lens that bends the light. And we found that people with a pigmented trabecular meshwork, it absorbs the energy a lot better. And patients with very, very pale trabecular meshwork, it struggles to absorb the energy. So it can work for some and not for others. Anytime you have an intervention on your eye, your inflammation will go up. And again, SLT works with inflammation. So you are going to increase the inflammation doing SLT. So for a period of time, 4 months, up to 6 months, your dry eyes can be worse. Debbie's gone quite far down the route with treatment. SLT early on didn't work. Had to have a trabeculectomy. That's the big operation. Needling is when the trabeculectomy, you create this drainage from inside to underneath the conjunctiva. And if the conjunctiva goes flat, we put a needle and try and lift it up again and put medicine to help the fluid to leave the eye out and to around the eye. So SLT twice, about 3 years apart, it works, but I needed drops. So it works as effectively as 1 eye drop. So if you're a patient who needs 3 medications to manage your glaucoma, you might only need 2. So that's the experience of treating people who've been on eye drops for some time with SLT. I think these days we're trying to do SLT first line. So you would have started on 1 eye drop. Depends when you came in. If you were picked up early by the optometrist and there was just some pressure rise, but not too bad glaucoma, that's a great patient for SLT. But if you've been picked up late, you presented late to the optometrist with very advanced glaucoma cupping, your pressure's at 38, then you probably SLT is not going to be the right thing for you. We're going to need to go on triple therapy, go in there very quickly and go in there hard with treatments and try and control it. Because I think more and more we attacking this more aggressively than we did in the past, just gently watching it go and upping slightly. I think we're doing very aggressive treatment and then hopefully tapering off and managing it long term. The pressure we always aimed for, well, we used to many years ago, was 18. Anything below 18 was considered good. But now we know that we want to get it as low as we can for that person, for that patient. So we individualize our target pressures. But, we used to say, oh, we got 18, that's fine. Let's just stay on 18 for a few months or years. But now we've got to, with the technology that we got, we can actually measure the nerve layer thickness. It's changed the way we manage, diagnose and manage glaucoma. And we used to rely heavily on the field test where you like push the button and look at the lights. That used to be a very good indicator for us, but now we're becoming the technology is becoming more and more refined, and we can do more and more. It's fantastic to have all this stuff available to us.
You mentioned a number of interventions that people can have either you or their specialists do. Can optometrists also do these?
And so what I've found, my experience is the optometrists here in New Zealand are exceedingly good in managing dry eye disease, and they run excellent clinics and they give excellent care. And a lot of the IPL is not done by the hospitals. A lot of the dry eye clinics are not run by the hospitals. So your optometrist is a great resource for dry eye disease. I think they don't use puncture plugs enough. I encourage them to use it more. But no, they're fantastic here in this country. So yes, use your optometrist as much as you can on managing, especially anterior blepharitis and meibomian gland dysfunction. Autoimmune diseases, once you've got that, so you've got the aqueous deficient dry eye disease. A lot of that is medical, and you'll need to come see an ophthalmologist or a corneal specialist for that. And the optometrists here are very good at prescribing medication, but prescribing serum eye drops, you probably need to be seen by an ophthalmologist for that. I just want to say thank you to everyone. Thank you for allowing me to speak to you guys this evening. I really do appreciate it. And it's always a pleasure to speak to you. And I'm hoping that we may do a few more talks on slightly different topics. So please do mention to the team if you've got anything specifically that you would like me to address. Send those through. I'm quite happy to cover any topics that I can, or find someone more suitably qualified to help if I need to.